A 58-year-old female on the respiratory ward was admitted with a pulmonary embolism 1 week ago and was started on warfarin at the time of diagnosis. She was covered with low molecular weight heparin until the INR was more than 2 for 24 hours. For the past week, she has been taking 4 mg of warfarin and her INR 4 days ago was 2.2. Her INR has been checked today and is 1.3. What is the most appropriate action to take? So she had pulmonary embolism 1 week ago, started on warfarin, covered with low molecular weight heparin for 24 hours, 4 mg of warfarin, INR 4 days ago was 2.2. INR been checked today and it's 1.3. So the appropriate action is to increase the dose of warfarin, right? Because the target is more than 2. What's the target INR? 2 to 3, right? I'm not sure. So what's the most appropriate action to take? Increase dose of warfarin to 6 mg and start low molecular weight heparin. Increase dose of warfarin to 6 mg. Start low molecular weight heparin, stop warfarin. Continue 4 mg warfarin and start low molecular weight heparin. Re-intake warfarin using local protocol. Reinitiate. Probably increase the dose. Oh, we need to start with low molecular weight heparin now also. Okay. As her INR is less than 2, she needs immediate anticoagulation with rapid-acting low molecular weight heparin. Her warfarin dose should also be increased to 6 mg. Her INR should be carefully monitored, and low molecular weight heparin discontinued when has adequate anticoagulation. Warfarin. Warfarin is an oral anticoagulant which inhibits epoxide reductase, preventing the reduction of vitamin K to its active hydroquinone form, which in turn acts as a cofactor in the carboxylation of clotting factor 2, 7, 9, and 10, mnemonic 1972, and protein C. Indications: venous thromboembolism, target INR 2.5, if recurrent 3.5. Atrial fibrillation, target INR 2.5. Mechanical heart valves, target INR depends on the valve type and location. Mitral valves generally require higher INR than aortic valves. 0.4 to 2.6 cm. Aortic valve looks smaller. Mitral valve looks bigger. Should be stasis rather than turbulence that causes more embolism due to mitral valve. There are two main types of oral anticoagulants, vitamin K antagonists, VKAs, and direct oral anticoagulants, DOACs. Warfarin, the most commonly used VKA, is a coumarin derivative that acts by inhibiting vitamin K-dependent clotting factors 2, 7, 9, and 10, in addition to the anticoagulant proteins C and S.
Proteins C and S are two anticoagulation proteins that inactivate coagulation factors 5A and 8A in the coagulation cascade. This means they act like brakes on coagulation, limiting clot formation and preventing clots from growing too big. So, when either of these proteins is deficient, it leads to a hypercoagulable state, meaning a person is at increased risk of developing a clot that could block blood flow. The most common places for such clots to develop are in the deep veins of the legs and in the vessels that carry deoxygenated blood through the lungs. Normally, protein C and protein S are two of many proteins or enzymes that regulate the complex process called hemostasis. This is where a solid clot forms in the flowing liquid blood to plug the defect in a damaged blood vessel. It has two steps. Primary hemostasis involves the formation of a platelet plug at the site of injury, and secondary hemostasis involves coagulation, where several clotting factors come into play to form a fibrin mesh over the platelet plug to reinforce it and form the blood clot. The main role of protein C and protein S is to prevent excess coagulation or fibrin formation during secondary hemostasis. Proteins C and S prevent excess coagulation by interacting with several other proteins involved in a complex system of checks and balances. So it starts with a protein called thromboembolic, which is on endothelial cells that line our blood vessels, and together with thrombin, they form a complex that also includes protein C and protein S. When protein S joins this complex, it activates the proteolytic site of protein C, which cleaves and inactivates active factor V. a cofactor for factor 10 in the common pathway, and factor 8, a cofactor for factor 9 in the intrinsic pathway. The factor 5 degradation product also binds to this complex and further enhances its ability to cleave more active factor 5 and active factor 8. By inhibiting both the intrinsic and common pathway, less fibrin is produced and coagulation slows down dramatically. So, in people with protein C and S deficiency, the thrombin thrombomodulin complex can't cleave and inactivate factors 5 and 8. This increases circulating factor 5 and factor 8 levels and tips the scale toward coagulation, putting them at increased risk for thrombosis or developing blood clots. This usually occurs in the deep veins of the legs or in the pulmonary arteries that carry deoxygenated blood from the heart to the lungs. There are two types of familial or congenital protein C and S deficiency. Both are inherited in an autosomal dominant manner. Type 1 disease is when there's not enough protein C or S, so there's a quantitative defect. Type 2 disease, however, is a qualitative defect, because enough protein C or S are made, but the proteins don't function properly. There are also acquired forms of protein C and S deficiency, like impaired production as seen in patients with liver disease or in patients taking warfarin, also called Coumadin. Another cause is excessive urinary loss of these proteins, which can happen in people with nephrotic syndrome. Protein C or S deficiency is commonly asymptomatic, but symptoms arise when a venous thromboembolism develops. That's when a clot forms, usually in the deep veins of the leg, and then parts of the clot can break off and travel to other parts of the body. Symptoms of venous thromboembolism include pain similar to a muscle cramp and swelling in the affected leg. If a clot breaks off and travels to the lungs, there can be signs of respiratory distress like pain with inhalation, fast heart rate, and a fast respiratory rate. If clots get lodged in the cerebral vessels, which usually occurs in a vein, it could cause headache, numbness or weakness in the face, arm, or leg, confusion, or slurred speech. Clots can also occur in veins in the abdomen, potentially causing signs or symptoms associated with injury to the liver, spleen, or intestine. A more serious presentation is neonatal purpura fulminans, which is when a newborn with protein C or S deficiency suffers massive arterial and venous thromboembolisms with hemorrhagic skin necrosis. Finally, with protein C or S deficiency, there can be warfarin-induced skin necrosis, which means tiny thrombi can form in the blood vessels of the skin, causing skin necrosis. This is a risk for people taking warfarin, especially in large doses, without an overlapping rapid onset blood thinner such as heparin or low molecular weight heparin. Protein C and S deficiency is suspected in people with a strong family history of coagulation disorders, especially those A more serious presentation is neonatal purpura fulminans, which is when a newborn with protein C or S deficiency suffers massive arterial and venous thromboembolisms with hemorrhagic skin necrosis. Finally, with protein C or S deficiency, there can be warfarin-induced skin necrosis, which means tiny thrombi can form in the blood vessels of the skin, causing skin necrosis. This is a risk for people taking warfarin, especially in large doses, without an overlapping rapid onset blood thinner such as heparin or low molecular weight heparin. Protein C and S deficiency is suspected in people with a strong family history.
So if you take warfarin, it's a vitamin K antagonist. Vitamin K antagonist. So your vitamin K related protein factors 2, 7, 9, 10 are affected. So it promotes blood thinning, or also known as anticoagulation. However, warfarin also inhibits the production of protein C and protein S. Protein C and protein S are responsible for anticoagulation. So when you start warfarin, when you initially start warfarin, especially when you're starting with a higher dose, you have a risk of causing a more prothrombotic state by inhibiting the protein C and protein S production initially. Okay.
History of coagulation disorders, especially those who suffer from recurrent venous thromboembolisms and experience their first thrombotic event before age 50. Protein C or protein S deficiency is also sometimes suspected when a venous thromboembolism develops in an unusual site, like the portal, mesenteric, or cerebral veins. Diagnosis is made by identifying low levels of protein C and S in the serum. Since warfarin can lower the levels of protein C and protein S, it is very important that a patient does not take warfarin for at least 2 to 4 weeks prior to being tested for protein C or protein S deficiency. Alright, as a quick recap. Protein C and protein S deficiency refer to two separate hereditary hypercoagulable disorders that involve the inability to inactivate factors 5 and 8 in the coagulation cascade. Most people present with venous thromboembolism, where a blood clot of the leg veins or lung circulation is most common. Initial treatment of venous thromboembolisms is the same as it would be for patients with normal protein C and protein S levels. However, identifying a low protein C or protein S level may, in some situations, impact long-term decisions about anticoagulation therapy.
Anticoagulation summary. There are two main types of oral anticoagulants, vitamin K antagonists VKAs and direct oral anticoagulants, the DOACs. Warfarin, the most common VKA, is a coumarin derivative that acts by inhibiting vitamin K dependent clotting factors 2, 7, 9, and 10, in addition to the anticoagulant proteins C and S. Warfarin has been used for decades as an anticoagulant. DOACs, apixaban, dabigatran, and doxaban and rivaroxaban are anticoagulants with a novel mode of action. Apixaban and doxaban and rivaroxaban are direct and reversible inhibitors of factor 10A. Inhibition of factor 10A prevents thrombin generation and thrombus development. Dabigatran is a reversible inhibitor of free thrombin, fibrin-bound thrombin, and thrombin-induced platelet aggregation. Warfarin is licensed for prophylaxis of embolization in the rheumatic heart disease. Warfarin is licensed for prophylaxis of embolization in rheumatic heart disease and atrial fibrillation, prophylaxis after insertion of prosthetic heart valve, prophylaxis and treatment of venous thrombosis and pulmonary embolism, and transient ischemic attacks. Apixaban, dabigatran, and doxaban rivaroxaban may be prescribed instead of warfarin for prevention of stroke and systemic embolisms in adults with non-valvular atrial fibrillation and at least one risk factor such as heart failure, hypertension, previous stroke, or transient ischemic attack aged 75 years and older, or diabetes mellitus. In addition, apixaban, dabigatran, doxaban, and rivaroxaban are licensed for the treatment of pulmonary embolism and deep vein thrombosis and prevention of recurrent DVT and PEs. Apixaban, dabigatran, and rivaroxaban are licensed for the prophylaxis of venous thromboembolism after elective hip or knee replacement surgery. Rivaroxaban is licensed for prophylaxis of atherothrombotic events following an acute coronary syndrome with elevated cardiac biomarkers in combination with aspirin alone or aspirin and clopidogrel, and for prophylaxis of atherothrombotic events in adults with coronary artery disease or symptomatic peripheral arterial disease at high risk of ischemic events in combination with aspirin. The most common adverse effect of anticoagulants is bleeding. Warfarin, apixaban, dabigatran, and rivaroxaban have antidotes for reversing their anticoagulant effects. There is currently no antidote for endoxaban. Unlike warfarin, DOACs do not require regular international normalized ratio (INR) monitoring. However, regular follow-up is required to review the treatment, assess for adverse effects such as bleeding, assess for thromboembolic events, and provide appropriate information and advice. Background information management. Warfarin. What's the starting dose when warfarin treatment is initiated? Baseline prothrombin measurements should be taken before starting treatment with warfarin. Prothrombin. The typical induction dose of warfarin is 10 mg daily for 2 days, but this should be tailored to individual requirements. A low starting dose of 5 mg is often more suitable for frail or elderly people, people with low body weight, people with liver disease or cardiac failure, and people at high risk of bleeding. Subsequent doses depend on the prothrombin time, reported as an international normalized ratio. The daily maintenance dose of warfarin is usually 3 to 9 milligrams, taken at the same time each day. The exact maintenance dose is depending on the INR, or rather appropriate anticoagulation test. Once the maintenance dose is stabilized in the therapeutic range, it is rarely necessary to alter it. When an immediate effect is required, for example in deep vein thrombosis or a pulmonary embolism, heparin or a low molecular heparin is given concurrently. This is done in secondary care. Where there is less urgency, as in people disposed to or at special risk of thromboembolism, anticoagulant treatment may be initiated with warfarin alone. Where there is less urgency, as in people disposed to or at special risk of thromboembolism, may be initiated with warfarin alone. For people with atrial fibrillation, there is no need to achieve anticoagulation rapidly. A slow loading regimen is safe and achieves therapeutic anticoagulation in most people within 3 to 4 weeks. Warfarin 1 mg to 2 mg daily is generally an acceptable starting dose. The average daily maintenance dose is usually around 5 mg daily. However, there is a wide variation, and the daily dose may vary between 1 to 15 mg for some people. Specialist advice should be sought if the person has a prolonged baseline prothrombin time. Monitoring the person's INR, prothrombin time. Long prothrombin time means you have a clotting problem, right? You can't clot properly. Monitoring the person's INR may be problematic, and an alternative anticoagulant may be required. What is the duration of treatment with warfarin? What are the contraindications and cautions? What are the adverse effects? What are the key drug interactions? Should warfarin be stopped before planned surgery or dental treatment? If a person needs to have surgery or any other invasive procedure, they may need to temporarily stop taking warfarin. Minor surgical procedures with low risk of bleeding can be performed in general without an international normalized ratio of less than 2.5. However, local recommendations should be considered. For surgery or other surgical procedures where there is a risk of severe bleeding, warfarin should be stopped for 3 to 5 days prior to the surgery or procedure. Where it is necessary to continue anticoagulation, for example, life-threatening thromboembolism, the INR should be reduced to less than 2.5 and heparin therapy should be started. If surgery is required and warfarin cannot be stopped 3 days beforehand, anticoagulation should be reversed with low-dose vitamin K. Surgery is required and warfarin cannot be stopped 3 days beforehand. Anticoagulation should be reversed with low-dose vitamin K. The timing for reinstating warfarin treatment depends on the risk of post-operative hemorrhage. In most instances, warfarin treatment can be restarted as soon as the person has oral intake. For dental procedures, in most cases, warfarin need not be stopped before the routine dental surgery, for example, tooth extraction. It is recommended the INR is checked 72 hours before dental surgery. The risk of significant bleeding in people with stable INR within the range of 2 to 4 is very small, but the risk of thrombosis may be increased if an oral or anticoagulants are temporarily discontinued. How should I monitor? How should I monitor during COVID-19? What is the target INR? How should I manage a person if their INR is not in the therapeutic range? What advice should I give a person receiving warfarin? What is self-testing and self-management? How should I monitor? The anticoagulant effect of warfarin is measured as the international normalized ratio INR. The INR calculation is based on the ratio between the prothrombin times of the test and the control samples. The INR is most accurately measured in venous blood samples, but many anticoagulation clinics use capillary blood samples because these are more convenient to obtain. Intravenous drug users and people who have Hep B or Hep C or HIV may be referred to a specialist clinic. Capillary blood sampling in this population may cause risk of transmission, and venous access is often difficult. Arrangements for monitoring the INR in such cases may vary with locality. Generally, the INR should be measured daily or on alternate days until it's within the therapeutic range, usually between 2 to 3, ideally 2.5 on 2 consecutive occasions. Although the INR may be measured each day after starting warfarin, a meaningful INR can only be obtained 3 to 4 days after starting treatment, then twice weekly for 1 to 2 weeks, followed by weekly measurements until at least 2 INR measurements are within the therapeutic range. Thereafter, depending on the stability of the INR at longer intervals, for example, up to every 12 weeks if agreed locally, once a stable warfarin dose that controls the INR has been established, changes in dose are seldom required. More frequent routine monitoring, for example, every 1 to 2 weeks of the INR is recommended for people at an increased risk of overcoagulation for people. For example, people with severe hypertension, liver disease, including alcoholic liver disease or renal failure. At increased risk of bleeding, for example, people with high intensity anticoagulation INR more than 4, and those of age 65 years and older, for whom adherence to treatment may be difficult. Reassess anticoagulation for a person with poor anticoagulation control indicated by any of the following: 2 INR values higher than 5 or 1 INR value higher than 8 within the past 6 months, 2 INR values less than 1.5 within the past 6 months. The time in therapeutic range is less than 65%. The person on warfarin should have all their results recorded in their yellow book with their dose instructions and their next appointment time. Be aware of the reasons for anticoagulation, their target INR, and the duration of their treatment. Receive appropriate information and advice on warfarin treatment. Warfarin metabolism can be affected by thyroid status. People with hypothyroidism or hyperthyroidism should be closely monitored on starting warfarin treatment. Genetic variability: if the person in a family member is known to have a polymorphism to the CYP2CP or VKORC1, extra care is warranted. What is a target INR for warfarin treatment? The maintenance dose of warfarin depends on the international normalized ratio during monitoring. The average daily maintenance dose of warfarin is around 5 mg taken at the same time every day. However, there is a wide variation from person to person, and the daily dose may lie between 1 to 15 mg for some people. And INR that is within 0.5 units of the target value is generally satisfactory. Larger deviations require dosage adjustment. Target values rather than ranges are now recommended. And a target INR of 2.5 is recommended for treatment of deep vein thrombosis, DVT, or pulmonary embolism, including those associated with antiphospholipid syndrome, or for recurrence in people with no longer receiving warfarin treatment. Atrial fibrillation. Cardioversion, take higher, target INR 2.5 for atrial fibrillation. Cardioversion as well, 2.5. Higher target values such as INR of 3 can be used for up to 4 weeks before the procedure to avoid cancellations due to low INR. Mitral stenosis or regurgitation with atrial fibrillation, history of systemic embolism, left atrial thrombus, or enlarged left atrium. With bioprosthesis in the mitral position, bioprosthetic valve, and history of systemic embolism, bioprosthetic valve and the left atrial thrombus at surgery, bioprosthetic valves, and the prothrombotic risk factors such as atrial fibrillation and low ventricular ejection fraction. Acute arterial embolism leading to embolectomy, dilated cardiomyopathy, post-myocardial infarction. A target INR of 3.5 is recommended for recurrent DVT or PE in people currently receiving anticoagulation and with an INR above 2. For mechanical prosthetic heart valves, the recommended INR depends on the type and location of valve and patient-related risk factors. Increasing INR target or adding an antiplatelet drug should be considered if an embolic event occurs whilst the person is anticoagulated at the target INR. See Table 1 for the recommended target INRs for mechanical valves. Prostatis thrombogenicity, low, medium, and high. NR target 2.5, 3, and 3.5. INR target patient-related risk factors 3, 3.5, 3.5. Patient-related risk factors for thrombosis include mitral, tricuspid, or pulmonary position. Previous arterial thromboembolism, atrial fibrillation, left atrial diameter more than 50. Mitral stenosis of any degree, left ventricular ejection fraction of less than 35%, left atrial dense spontaneous echo contrast. How should I manage a person if their INR is not in the therapeutic range? If the international normalized ratio INR is outside the therapeutic range, ask the person about any changes in order to find the cause of the out-of-range result. For example, ask about adherence to warfarin treatment. For example, if they have missed any doses or taken too much. Use of other medications, including over-the-counter products, vitamins, and herbal or homeopathic remedies. Use of alcohol or illicit drugs. Food and drink intake, for example, green vegetables and cranberry juice. Their general health. Weight loss, acute illness such as gastroenteritis, and smoking cessation can increase the effect of warfarin. Weight gain, diarrhea, and vomiting can reduce the effect of warfarin. If the person has major bleeding, stop warfarin and refer urgently for intravenous treatment with phytomenadione, vitamin K1, and dried prothrombin complex concentrate, factors 2, 7, 9, and 10, or fresh frozen plasma if dried prothrombin complex are unavailable. Oh, I wasn't paying attention. If the INR is outside the therapeutic range, ask why. So sometimes it's because they're not taking their medications. Sometimes they're taking other medications that might interact with it. Sometimes they might be taking alcohol, illicit drugs. Sometimes it might be certain foods that affect the enzymes. Their general health, weight loss, acute illness such as gastroenteritis, and smoking cessation can increase the effect of warfarin. Weight gain, diarrhea, and vomiting can reduce the effect of warfarin. If a person has major bleeding, stop warfarin and refer urgently for intravenous treatment and phytomenadione, vitamin K1, and dried prothrombin complex concentrate, factors 2, 7, 9, and 10. Or fresh frozen plasma if dried prothrombin complex is unavailable. If the INR is high and is greater than 8 with minor bleeding, stop warfarin and give phytomenadione by slow intravenous injection. The dose of phytomenadione may be repeated after 24 hours if the INR is still too high. Restart warfarin when the INR is less than 5. Greater than 8 with no bleeding, stop warfarin and give phytomenadione by mouth using the intravenous preparation orally off-label use. The dose of phytomenadione may be repeated after 24 hours if INR is still too high. Restart warfarin when the INR is less than 5. Between 5 to 8 with minor bleeding, stop warfarin and give vitamin by slow intravenous injection. Restart warfarin when INR is less than 5. Between 5 to 8 with no bleeding, withhold 1 to 2 doses of warfarin and reduce subsequent maintenance dose. If there is unexpected bleeding at therapeutic levels, always investigate possibility of underlying cause such as unsuspected renal or gastric GI tract pathology. Yep. Okay. No mention of low molecular weight heparin being given when INR is less than 2, though. I guess it's just 1 week after the pulmonary embolism, so you want to err on the side of caution.